type of hearing loss or severity of hearing loss or something to do with hearing loss. And the way you're looking at me makes me think we're not even talking about hearing loss. I should have just started talking about earwax.
Welcome to the Ask an Audiologist podcast, real audiology white papers written by real audiologists and explained to you by a real audiologist and a guy who isn't. Now here are your hosts, Dr. Jordan Strong and Kevin Ziener.
Welcome back to another episode of Ask an Audiologist. I'm Kevin Ziener.
I'm Dr. Jordan Strong.
In today's episode, we're going to go inside the hearing exam process and talk about something called Real Ear, written by Dr. Mary Carson of Clarity Audiology and Hearing Solutions in Ellicott City, Maryland. We will talk about the importance of real ear as it relates to identifying an individual's precise hearing loss. Now, Dr. Jordan, I wrote that not actually having any understanding of real ear or what real ear does. I just know it's a part of the process to hopefully identifying a patient's type of hearing loss or severity of hearing loss or something to do with hearing loss. And the way you're looking at me makes me think we're not even talking about hearing loss. I should have just started talking about earwax. What is real ear and why do we need to know about it?
So real ear is actually where it's part of the hearing aid programming process.
Oh, that's what I was going to say next.
Yes. Good guess.
Thank
Good
you.
guess.
Yeah. You said it before I could say it. Okay.
Yeah. So real ear measures is actually the only way that we can make sure that the hearing aid is producing what we want it to produce to that person's ear.
Got it.
So what can happen is any time that we're putting something in the ear, it's changing the acoustics of their ear.
Sure.
First and foremost. Second, depending on the size and shape of that ear canal, it can change the sound pressure level in that ear.
Got it.
So whenever we put something in there, it's like if you're singing in a bathroom versus if you're singing like on a stage, the acoustics are different.
Yes, I sound phenomenal in one and horrible in the other, as I'm sure most people do.
So that's going to change the sound pressure level if you're in a smaller room versus a bigger room, smaller ear canal versus a bigger ear canal. So this test, it uses a very small, what we call a probe tube. It's a little clear little microphone that goes down into the ear canal where we test without the hearing aid first and measure what does the ear canal look like, what does it sound like when there's nothing in it versus when the hearing aid is in it but the hearing aid is off. Okay. Like what are we taking away from that ear canal?
So it's like getting like, if with nothing here, this is just what the ear is kind of hearing.
Correct.
And then when we've put in what we hope to be the right hearing aid with the right settings, this is what the ear hears now.
Right.
So it's trying to, if I'm wrong, Lord knows I've already started this podcast wrong. It's trying to mimic what the real ear is trying to mimic what we, the patient, are actually hearing or how we hear.
Right. So we're trying to restore as natural hearing as possible.
Got it.
So we want soft sounds to sound soft, medium sounds to sound like a medium sound, and a loud sound to be a loud sound.
Okay.
But within the realm of that person's hearing.
Okay.
So I don't want a loud sound to sound abnormally loud, nor do I want a loud sound to sound soft.
Totally.
You know, we want it to sound like it should.
Yes.
So by using real ear, it produces targets for us.
Okay.
So we're matching that prescription of that hearing aid to those targets based on what we obtained in that real ear measurement.
Now, here's what's interesting because I've seen real ear be used, and what you just described sounds like it would be a 5-hour process. It's like insanely fast.
It is very
minutes. How is... Now, again, you're going to tell me like, well, because we're not dumb, Kevin, but how are you able to do something that sounds so complicated, so fast, and have the exact right results?
Technology has evolved so much.
I'm telling you.
So much.
But in the time it took you to explain it, you could have done a real ear measurement.
I mean, I normally tell my patients, I'm going to do this this procedure. You don't have to do anything.
Right.
You're going to feel me put a little probe tube down in your ear. It feels like there's a hair in your ear as I put it in there. And then you're going to hear this machine make some noise. And you don't have to do anything. I'm taking a measurement. Yeah. It's going to take me about 3 to 5 minutes.
Got it.
That's really it.
And that is, now this like technology is kind of like an 80s baby. It's been around for 40 some odd years.
Yeah.
Obviously, you weren't around then to use it. I imagine that it continually gets better as technology itself gets better. But even still, I imagine it's insanely accurate for the most part.
Absolutely.
How much can Real Ear take you before you start tinkering with the actual hearing aid or listening to what the patient themselves is saying?
Yeah. So for the most part, the whole time that it's running, we're kind of tweaking things.
Sure.
Because we have those targets. We're looking at this graph and it's kind of constantly changing with the input that it's being given.
Yeah.
And based on that input, we're constantly going through and looking at frequency by frequency of what needs to be adjusted to match those targets.
Got it.
Within 5 minutes.
That's crazy. And so I'm trying to think in my experience with Real Ear, you already have a hearing aid picked out, right? Then you go through Real Ear and then you, assuming that it's the right hearing aid, kind of know if you're on par. Yeah,
this is part of typically the fit and orientation of the hearing aid part. So we've already been through the hearing test. We've done all of those things. And now we're at the point where, okay, you need to be treated. Most appropriate treatment for you is going to be a hearing aid. Now let's program it for you and get it customized for your hearing loss.
Now, how often do you need to use Real Ear? Like, so if I'm a patient, I've been diagnosed, I've been treated, I've gone through Real Ear, I'm coming up for a follow-up or an annual.
Sure.
Do you still use it, or do we just kind of assume we're good for a while?
So it gives us a good baseline for sure. But if anything changes, if we have to send that hearing aid for repair, or if your hearing changes, we've changed something on the acoustics of that hearing aid. So like the tip that goes on the end, have we changed the dome? Have we changed the ear mold? Any of those things, then we need to redo Real Ear and just check and see, what's different.
Sure. And then of course, if you're due for an upgrade in technology, you'll probably do it then as well.
Absolutely.
Now, I have only ever seen this used out in the field for like philanthropic trips that I've been on. Am I right in assuming that it's the same thing in practice, where it's like those big kind of headphone cans, and then it's got that big bridge over the top, and it's got like antenna popping out where it looks like you're from the Jetsons or something like that? No? Okay.
No, those are used in the field a lot, especially in those types of events. There are a few different manufacturers that make them. The one that we use, which is definitely one of the most popular that's out there, has kind of a neck loop, if you will, that goes around your neck, kind of sits on your shoulders, and then it has an earpiece that just kind of hangs over the ear with the little tube that goes down in the ear.
Got it.
So not as big and cumbersome as that.
Yeah, it's tough for anybody to just not look like an idiot wearing those. Like, and I mean this like universal, children, adults, senior citizen, man, woman. Like when you have that thing strapped on that it looks like you're in a 1960s Russian submarine, you're like, I think I might just want hearing loss instead of having to go through this process.
3 minutes.
Yeah,
3 minutes.
3 minutes, exactly. You just look stupid for 3 minutes, promise. What else? Because I know this is like a highly intricate process, and you could explain the ins and outs of it, and we would lose the entire listening audience.
Oh, yeah.
But like, I know there's speech mapping. I know there's, insertion of gain. I know there's all this other stuff, but like, what is another main component that might pique people's interest?
Well, that hearing aid is only as good as it is programmed.
Got it.
So it's like if you pick up somebody else's glasses and try to wear them, it's useless.
Got it.
You can't see through those glasses. In the same way with these hearing aids. If we haven't really programmed them down to the nitty gritty of fine tuning it for you and for the environments and the situations that you're in, then we haven't done our job.
And that's what she's paid to do.
There you go.
Her job.
I am.
And now that you know the real scoop on Real Ear, see what I did there? You can go to askanaudiologist.com for articles like this or for anything else audiology related. Dr. Jordan, this is our last podcast with you for the year.
Woo.
So I say this, see you next year.
See you next year.
And we'll see you guys next week.
You can find more information at askanaudiologist.com, and you can follow us on all our social channels at Ask an Audiologist. The information provided on this podcast is for educational and entertainment purposes only and does not substitute for professional medical advice.
Lots of different things can cause fullness, and I'm going to be honest, there are some patients that I see
that everything checks out and it's completely normal.
Yeah.
And we just don't know why they're feeling full.
Yeah.
Why their ears are feeling full, rather. We know
It's
why
the
their
holiday
hearts are
season.
full.
We know why they're full.
Why their bellies and their hearts are
Yes.
full, right?